Well, good afternoon and welcome to all of you. Welcome to our virtual Compassion in Action Healthcare Conference. I'm Dr. Beth Lown, the Chief Medical Officer of the Schwartz Center for Compassion in Healthcare, and we are all very, very happy to welcome you to this session of our conference. We're glad you've chosen to join us today. Thank you. We have a terrific session planned for you today, and I'm just so excited and happy to welcome Dr. Stephen Trzeciak, who is a professor, chair, and Chief of Medicine at Cooper University Healthcare and Cooper Medical School of Rowan University, who is going to talk to us about compassion today. If you have any questions for Dr. Trzeciak during the presentation, please enter them into the Q&A box that you'll see at the bottom of your screen. And there will be time to answer questions towards the end of the session. So Dr. Trzeciak, it is a pleasure to have you join us today. Thank you so very, very much.
Thank you so much, Beth. It is such an honor to be here today. I want to thank you for the opportunity to participate. And I want to thank all of your colleagues at the Schwartz Center and Melissa and the whole team for the opportunity and for the invitation. Anytime that I get to be associated with the Schwartz Center and just understanding the magnitude and of the impact that your organization has had on healthcare, it's just really an honor and a pleasure, and I thank you for that. So I'm going to talk to you for a little bit about a concept that I've been working on for the last couple of years. I call it compassionomics. It might be a term that you're not familiar with. That's because we made it up. Essentially, we needed a term to refer to the fact that compassion matters not just in meaningful ways, but also in measurable ways. If you're rigorous enough in your approach and synthesizing all the information, and you have your mind open to the fact that quantitative effects can actually be realized. I'm going to talk to you about that for a bit, and then I'm specifically going to be talking about compassion in times of crisis, which is clearly where we are right now in 2020. And how is it that compassion can matter even more when we're going through what we're going through? So I'm an intensivist, so just a bit about me. I'm an intensivist, a specialist in intensive care medicine. In fact, I was just in the ICU a couple hours ago, hence the scrubs today. I spent the first 20 years of my career doing resuscitation science research in the ICU. And now I study compassion science. I study compassion in healthcare. And that was certainly a change in trajectory for my career. We don't have time for the whole story of the why behind that, but in short, I became convicted of the fact that the most pressing problem of our time is an erosion of compassion. And I believe that that's true in the world in general. When you get down to the root causes of what we're experiencing and going through as a society, I think the underpinning is a lack of compassion. But I believe that's also true for healthcare. And it led me to a journey through the evidence for the effects of compassion in healthcare, and I'll be sharing that with you today. And we're going to talk about the power of compassion, not just for patients, but for the giver too. And there are two things that I want to tell you before I really get into the data today. They're not really disclaimers, but things I want you to understand my thinking on this. The first is that I don't have any kind of magical thinking about compassion. What I mean by that is that the number one determinant of clinical outcome is clinical excellence. So I'm just going to say that one more time just to be clear. The number one determinant of clinical outcome is clinical excellence. So for example, if you're a physician and you prescribe the wrong medication, or if you're a surgeon and you botch your surgery, there's no amount of compassion that's going to undo that. But it's not an either or, it's an and. Clinical excellence plus compassion gives the best opportunity for a good outcome. And that's what we're going to be talking about today. When I'm an author, a co-author of a book called Compassionomics, and I'm going to I just remembered I need to share my screen here. So when the book first came out, the Washington Post had a social media post about an article that they did about the book. And the tagline in the social media post is, would you rather have a physician who graduated at the top of the class in medical school or a physician who's compassionate? As if it's an either or. I urge you not to take the bait on that one. That is a false choice. It's clinical excellence plus compassion yields the best outcomes. And so that's just something I want you to understand before I get into the data today. The other thing I want you to understand is that you may be thinking that because I was invited to speak to you all today in the Schwartz Center rounds, and because I wrote a book about compassion science, that I must be the most compassionate doctor. And I wish that were true. I am a work in progress, very much so, but I'm working hard to get better at compassion every day. And that's because I see it now. I see the evidence. I see the effects. I want to get better, which is really important. And so I'm trying really hard. So I mentioned to you that, that we have an erosion of compassion, a compassion crisis, if you will. Let me share with you some data that, that made me start to think about this. So on February 27th, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, two buses collided head on. If you can see my slides, you see what is left of one of the buses, sheared in half along the long axis. The wreckage and the extrication of victims from this crash scene were so complex that it actually made it into the annals of a disaster medicine textbook. Tragically, 6 people died, but miraculously, 56 people were saved. Now, 5 years later, researchers asked the question, what do survivors remember? What do survivors remember? They used a rigorous qualitative research methodology, and they interviewed every survivor, and they found 2 common themes in the data. The first was expected. It was the physical pain that they felt at the moment of impact. But the other theme, it was a lack of compassion from the caregivers at the hospital. And the data become even more compelling when you realize that the survivors from this scene were taken to multiple different trauma centers, and they all had the same experience. These data began to open my eyes to a stark reality. In healthcare, we're in the midst of a compassion crisis. Data from Dr. Lown and colleagues has pointed to this. It's published in Health Affairs. A survey of 1,300 patients and physicians in the United States found that nearly half of all patients and physicians believe that the healthcare system is not compassionate. But when you ask them about healthcare providers, the patients still feel the same way. Nearly half believe our healthcare providers are not compassionate. Research from multiple different studies have shown that clinicians miss 60 to 90% of opportunities to respond to patients with compassion. And in fact, that statements of compassion from physicians to patients comprises less than 1% of all interactions in an office visit setting. The Mayo Clinic has published data that the median time to first interruption of a patient when they're trying to state their main reason for visiting the doctor is just 11 seconds. In my domain, critical care, research from Johns Hopkins University has found that 74% of interactions between ICU staff and patients or families in the ICU have no expression of compassion. And perhaps the most striking, a University of Washington study funded by the NIH found that in end-of-life decision conferences in the ICU with patients and families, fully 1/3 of those end-of-life conversations had an absence of any statement of compassion from the care team to the patients or the families. Of course, we're going through an epidemic of burnout in healthcare. That was certainly true before the crisis of 2020 and COVID. And burnout, one of the cornerstones is depersonalization, an inability to make a personal connection. And so that fuels the crisis that we're going through with compassion. And with electronic health records, there's evidence that clinicians spend more time looking into computer screens than looking their patients in the eyes. Based on all of these data and more, I submit to you for your consideration that we're in the midst of a compassion crisis. But here's the big question. Does it matter? Does compassion really matter? Now, you may say, of course, compassion matters. We ought to treat all patients with compassion. It's a cornerstone of the art of medicine. Of course, I agree. But does compassion just belong in the art of medicine, or are there also evidence-based effects belonging in the science of medicine? And what is the evidence? So I'm a research nerd by background, and so I wanted to test a hypothesis. My hypothesis was that compassion matters for patients, for patient care, and for those who care for patients. So my colleague Anthony Mazzarelli and I set off on a 2-year journey through the data using a number of approaches to synthesize the data, including systematic review. And we went through 1,000 scientific abstracts, more than 280 original science research papers. And today I'm going to share with you just a little bit of what we found. Before we do that, we do need to have some definitions. And I recognize that definition of compassion and related terms are often debated. But what I found in going through all the evidence is that scientists typically agree or more often than not, and the working definition that we use in our group for compassion is an emotional response, that compassion is an emotional response to another's pain or suffering involving an authentic desire to help. It's a bit different from a very closely related term, empathy. Empathy is the sensing, detecting, feeling, and understanding of another's emotions, having it resonate with you and understanding, sharing their perspective. So compassion is different because it also involves taking action. Now, of course, empathy is vital because if you don't sense or detect another person's pain or suffering, you'll never see the opportunity to respond to them with compassion. Empathy is a precursor for compassion. And there are neuroscience underpinnings for these distinction in terms. So for example, when you witness someone in pain or suffering, and it's uncomfortable for you, it's painful for you, research using functional MRI of the brain have identified that it actually hits you right in the pain center of the brain, as opposed to when you take action to alleviate someone's suffering to some extent, it triggers reward pathways in the brain that's associated with affiliation and positive affect. So you might say that empathy hurts, but compassion heals. And my colleague, Anthony Mazzarelli, likes to say you can't have compassion through a one-way mirror. You could have empathy, but you can't have compassion. And now that we've talked about those terms, the easiest way to summarize it was suggested to us one time by Dr. Don Berwick from the Institute of Healthcare Improvement. He just said it quite simply: empathy plus action equals compassion. So I'm going to talk now about some of the effects of compassion for patients. I think it's important to first realize that there is an abundance of data that for good health, human connection matters. Relationships matter. Take, for example, the Harvard study of adult development. What they found was that the best predictor of longevity into your 80s wasn't some biomarker in your 50s. It wasn't your cholesterol, your blood pressure, your hemoglobin A1C. It was the quality of one's relationships. On the flip side, we know that there is abundant data that loneliness is associated with adverse health outcomes. And if it's true that human connection matters in the broad sense, then could that also be true within the context of healthcare? And so on this slide, you can see just the general domains for the clinical effects of compassion on patients, the physiological, the psychological, effects on quality of care or patient self-care. Of course, I can't go through all of the studies with you today. Of the 280 original science research papers that are cited in Compassionomics, more than 100 are on effects for patients. But in general, compassion can modulate stress-mediated disease. It can modulate patients' experience of pain. There are immune system effects and endocrine effects. I'm thinking of a study from Boston, published now years ago, from 2 randomized controlled trials in the domain of anesthesiology. One published in JAMA and the other in the New England Journal of Medicine, where they tested what they called a special care intervention from an anesthesiologist. So a separate, extra, additional visit from an anesthesiologist before you get wheeled in for surgery, which of course is one of the most vulnerable times in anyone's life. What they found is that this special care visit that was built on rapport building, allaying people's fears, and giving people reassurance, that when they compared that in a randomized trial against a very powerful sedative, pentobarbital, they found that patients who received pentobarbital were drowsy but not calm, whereas patients who were treated with special care from the anesthesiologist were calm but not drowsy. And in a follow-up study, they found that the special care from the anesthesiologist was associated with a reduction in the need for opiate pain medications following surgery. There's evidence that human connection can modulate patients' perception of pain. Now, this is known from experimental science in laboratories with experimentally induced pain. So the touch of a trusted other reduces people's experience of pain under laboratory conditions. But is it also true in the clinic? And there is evidence for that, not just post-operative pain, but also low back pain, abdominal pain related to irritable bowel syndrome, also migraine headache pain. I mentioned earlier immune system effects. So there was a University of Wisconsin study sponsored by the NIH who tested the association between compassion from clinicians and recovery from the common cold. What they found is that optimal compassion from clinicians was associated with changes in immune system response. So there were changes in the interleukins from the nasal washings in these patients with the common cold. There was also with optimal compassion, there was a 15% reduction in the time and the severity, the duration and the severity of cold symptoms. Some of my colleagues right across the river from me at Jefferson have studied the association between compassion and outcomes in patients with diabetes. And they found that optimal compassion is associated with an 80% higher odds of optimal blood glucose control and 41% lower odds of acute diabetic complications requiring admission to the hospital. Now, turning to psychological effects, it may be intuitive to some extent that compassion from another human being can help with our mental health. But this has also been studied quite rigorously. Studies from University of Pennsylvania, Duke University, University of Colorado, supported by the NIH, have found that there is a moderate to large effect size in patients with depression with the compassion from the treating therapist. meaning compassion of the therapist, the individual trait of compassion from the therapist is associated with a moderate to large effect in reducing symptoms of depressions in patients who suffer from depression. There are also numerous studies which show compassion is associated with decreased anxiety. And also, compassion of therapists can be, and treating clinicians can be associated with lower psychological distress for people going through somatic disease. So, for example, people who are suffering from cancer. Self-care is one of the most important categories when it comes to understanding the effects of compassion. So this is, how do patients take care of themselves in all the time that they are away from their healthcare providers, which is like 99.9% of the time in the year, correct? So if you care deeply for patients and they know that, they're more likely to take their medicine versus being non-adherent to what you prescribe. In fact, there's evidence that for clinicians who don't treat patients with compassion, the patients are less likely to even remember the discharge instructions in the first place. It's as if they stopped listening to the instructions, perhaps because they think that the clinician doesn't even care. So this talk of adherence reminds me about a Johns Hopkins study of 1,700 patients with HIV. Now, HIV is a disease in which it's very much controllable in 2020, but it is vital to adhere, to be very adherent, perfectly adherent if possible, to the antiretroviral therapy. So these Hopkins investigators asked the question to HIV patients, does your HIV provider know you as a person? Does your provider know you as a person? What they found is that no, and they adjusted the analysis for every other factor that they knew to be associated with adherence to therapy or being non-adherent to therapy. What they found was that knowing the patient as a person was associated with a 33% higher odds of adherence to therapy, but also a 20% higher odds of having no detectable virus in the blood after adjustment for all potential confounders that were measurable. So let's think about that. So the patient believes that their clinician knows them as a person. It increases their self-efficacy, their belief that they can actually control this disease. They are more likely to take their medicine and more likely to have no detectable virus in the blood. In my opinion, that's powerful evidence for the power of knowing a patient as a person, which is a cornerstone of treating somebody with compassion. In terms of quality of care, there are really two signals that can be important in assessing the association between compassion and quality of care. One is that the presence of compassion is associated with better quality. The opposite is that the absence of compassion is associated with worse quality. So there are numerous studies that show that with more compassion for patients, there is better patient disclosure. So they're more likely to tell you what's really troubling them and share the most. When in medicine, we have the privilege of understanding people's most private matters. And so this is enhanced when you treat people with compassion. They're more likely to tell you what's really wrong with them. And it's also true that they will remember your discharge instructions better when you have more empathy and more compassion for patients. The absence of compassion has very important signals of lower patient safety. So for example, let's take the data on depersonalization. So we said earlier, depersonalization is one of the cornerstones of the burnout syndrome. So it is an inability to make a personal connection. Depersonalization is not the opposite of compassion, but when you can't even know to make any kind of personal connection, I would submit to you that there has to be an absence of compassion because you can't even make a personal connection with a patient. What a number of investigators, most notably investigators from the Mayo Clinic, have found that errors are much higher where depersonalization is high. That's been found on medical wards, that's been found among surgeons. The number one reason or explanation for this association between high depersonalization, which I believe translates to lower compassion, and higher errors, is that people, when they have depersonalization, they're more likely to cut corners. And perhaps in your careers, you've been exposed to colleagues who you think they don't really care very much, and maybe they're also sloppy in their technical proficiency as well. That's not necessarily causation, of course, but it's evidence of association in that they run together. The last thing I want to talk to you about before I get into compassion in times of crisis and what we're facing right now in 2020 is I want to talk to you about burnout. And I have been through all of the literature. I used to believe because I was taught this when I was a medical student back in the early 1990s. The hidden curriculum would teach us don't show too much compassion. Don't have too much compassion for patients because it'll make you more likely to get burned out. Too much caring will burn you out. And I remember being taught that. And I've gone through the evidence, and the preponderance of evidence in the biomedical literature actually suggests the opposite. What I mean by that is high compassion, low burnout, low compassion, high burnout. And how could this be, or what could be an explanation for this? And those signals are very consistent throughout the literature. One explanation that I have is that people who have more compassion connect more with patients, and they get that very positive experience of a very close clinician-patient relationship. That's fulfilling. It makes us love what we do, and that builds resilience and resistance to burnout. And so that is and actually I experienced that myself after about 20 years of working in an ICU. I found that when I focus more on caring for patients and building those connections, that my symptoms of burnout are markedly reduced. And so I found it to be very powerful on a personal level. Next, I want to talk about where we are today in 2020 and why I think that compassion is more important now than perhaps ever before in our practice lifetimes, in the last few decades that we've been practicing, or at least that I've been practicing. And we're in a confluence, I believe, of crises. A confluence. We have COVID-19, which is something that we haven't seen here for 100 years. But we also have the brutal killings of George Floyd, Breonna Taylor, Ahmaud Arbery. Really, we have a confluence of injustices, because while, of course, those killings are injustices, we also have marked disparities in outcomes, both the incidence and outcomes from COVID-19. And so I want to talk about this confluence and why I think compassion is vital in each of these cases. First, with COVID, in disasters, the human spirit often shines, and people pull together, band together, and you see amazing acts of heroism. But not always. Not always. One notable exception in history has been pandemics. And why is that? Perhaps it's because the enemy is invisible, and the enemy can be in any one of us. And so and coupled with the requirement for physical distancing, we have fear. So we can literally be afraid of each other. And obviously that can drive people apart. What's been especially different about this experience than anything I've experienced in the last 20 years working in the ICU is, of course, we have for very good reasons, but we have visitor restrictions. And when we don't have visitors, patients don't have their families. Families obviously can't see and connect with the patients, and everybody suffers. And what I have witnessed is this countercurrent contagion of compassion amongst my team. not just in the ICU, but broadly throughout the Department of Medicine. And I've seen our caregivers rise up to the challenge and realize that because their families aren't there, that they have to fill that void to the extent possible. And for example, just a couple of hours ago when I was in the ICU, I had received a phone call from a good friend of mine who I've known for 20 years. And her husband got admitted to the hospital, and she was very worried about him coming to the ICU. And one of my colleagues was the intensivist taking care of him. And when I went to the bedside to check on my friend's spouse, I found my colleague, Dr. Lars Peterson, who is a wonderful intensivist and an amazingly compassionate person, FaceTiming with the family and with the patients so that she could see that he was okay and he could tell her that he was going to be okay. And it was just a really powerful moment. And things like that, those sort of compassion connections are, we're seeing them regularly. And for me, I'm reminded of a term called elevation. So social scientists, psychologists recognize elevation, the work of Jonathan Haidt and colleagues. It's an uplifting emotional state in which when you witness others' moral excellence and heroism, it makes you want to behave similarly. And so I've just been inspired by my colleagues, especially those who have gone to have shown more compassion than they ever have before. And that's been really, really important to see and inspiring to me personally. And I also think that it's important to recognize that compassion is tied to hope. And now hope is a word that sometimes gets a bad rap in medicine, right? Because people think of hope as something you believe with no credible evidence, some sort of Pollyanna-like sort of sentiment. And I don't believe that that's true. I think that hope is vital. And compassion combats people's demoralization, and it's a powerful restorer of hope. And I know sometimes in business and other circles, people will say, well, hope is not a strategy, but I would say that hope is necessary for every strategy, including our strategy for getting through pandemics like we've never seen before. And so those are my thoughts on COVID, and I'm just going to change my focus right now to the disparities that we're seeing, not only with COVID, but just in healthcare more broadly, where people who are disadvantaged either by race, ethnicity, or socioeconomic status have different outcomes from white, non-disadvantaged persons. And this has certainly been true with COVID-19. We see that people of color are not only getting more cases of COVID-19, but are having worse outcomes and higher mortality. And when you consider that, that it's an injustice, in my opinion, that disparity, and what's driving that. And my mind goes to three things during this time. One is compassion. Number two is empathy. And number three is humanity. So earlier on in the hour, I said that empathy was a precursor for compassion. And it is. It's a vital precursor for compassion, because if we don't see and detect and recognize the opportunity or the pain and suffering, we'll never be motivated to take action with compassion. But I believe that there's also an antecedent to empathy. And the antecedent to empathy is fully seeing another person's humanity. If you fail to fully see another person's humanity, then empathy fails, and so does compassion. And for obvious reasons, we're talking a whole lot about racism, especially in the US these days. And I believe that racism involves a failure to see our shared humanity. In the killing of George Floyd, I believe that we were witnessing a failure to see Mr. Floyd's humanity. And in these healthcare disparities related to COVID-19, but broadly across all disparities, we have an institutionalized failure to fully see the humanity of disadvantaged people. Now, I personally have never felt the effects of racism. I can't fathom what it feels like to have one's humanity go unseen, or to have indifference towards one's humanity through institutionalized racism. But we need to identify those the causes of those disparities and why there are structural components to racism that affect medicine, and we need to work to eliminate them. The last thing I'll leave you with before I conclude my remarks and we go to Q&A is I'm wondering a lot lately about what our patients are experiencing. And what I mean by that is that at a systems level, all healthcare disparities are likely rooted in a lack of compassion for disadvantaged persons. But what about at the individual interpersonal level? And we know enough about implicit bias to know that it is pervasive. Perhaps it is sorry, I'm just having a little bit of trouble with my computer here. Hopefully you can still hear me. I'm just going to conclude by saying that my research group is now involved in research to detect what patients are experiencing and whether or not healthcare disparities exist in patient experience of clinician compassion. So I want to thank you all for your attention today, and I want to thank everybody at the Schwartz Center for the opportunity to be here. It is such an honor, and I thank you all very much for this invitation.
Thank you very, very much, Steve. That's a terrific set of reflections, and it's such a wonderful summary of the research as well. We really appreciate it.
Thank you. Thank you so much.
Yeah, there are some comments and some questions, and I am sure that there will be more as we move along. I think some folks want to hear you comment about this notion of compassion fatigue. Does compassion really fatigue, do you think? What is that all about?
Well, I know that there are, so first of all, I should say that I see there are 71 participants on this. It's very likely that there are people who know a whole lot more about that than me. I'll just tell you briefly my thinking on that, is that self-other distinction is really important. So like, for example, you can be aware in the moment that someone is going through tragedy, and yet at the same time be aware that it's not your tragedy, right? And I think when I think of compassion fatigue, and from what I've read and all the work that we did for the book, sometimes when people experience that as their own pain and a lack of self-other distinction, and when I say self-other distinction, much of this goes to the work of Tanya Singer, who's a neuroscientist at the Max Planck Institute in Germany. The inability to have that self-other distinction is something that leads to burnout, and I think that that's really what's those experiences really are what we're talking about in compassion fatigue.
That's interesting. I think some people think that just being unable to regulate your emotions also, so that you become overwhelmed by the empathic distress of others, contributes to that as well.
Yeah, for sure.
So, yeah. Another question here. Well, there's plenty of questions. One person wants to know about work on long-term care residents and compassion, whether or not you've discovered anything in your research about that.
So there is an investigator at University of Pennsylvania by the name of Siegel Barsad.
Yes.
And I don't know her personally. I'm aware of her work. She did a wonderful study years back that was published in Administrative Science Quarterly, in which she studied the culture in long-term care centers. So there were 13 long-term care centers in the Northeast US in this study. And what she found, or actually what they measured was the staff opinion about how others behave. So it wasn't about how they behave, but what behaviors do you see around you from your colleagues? And they had a validated instrument to assess whether or not they had a compassionate culture in the long-term care centers. And what they found was that a culture of compassion was associated with less burnout among care workers. Also, and this is important, I believe, less missed time, less absenteeism, so not fewer sick days, for example. But interestingly, something different with the patients as well. There were fewer visits to the emergency department from those long-term care centers that had a culture of compassion. So perhaps in some cases, long-term care center staffs may just be quick to send somebody to the emergency department, whereas in those where there was a culture of compassion, the data would indicate that somehow they were able to avoid that. So as it relates to culture, I'm aware of some of that data, and I think it's really a great way to study it.
Steve, was that, did she call that companionate love?
Yeah, that's a term I'd never heard before.
Me either.
But it works.
I think she was also interested in talking about compassion shown from staff to staff as well, as part of that culture of compassion, I think.
Yeah, for sure. Yeah.
So that was Siegel Barsad. Somebody was asking for the name of that study.
It was.
Barsade. Other questions here. Let me just look through the Q&A. This is an interesting question too. Given the lack of family support in the continuing pandemic, what ideas and practices beyond having their direct providers have you seen that create key connections with family friends on the outside? And you mentioned the FaceTiming, of course.
Yeah, we two things. Number one is that we had a program with our medical students at Cooper Medical School at Rowan University here in Camden. And we called it, when I say we, it's actually my colleagues that created this. They called it Critical. And what it would be is that our medical students were able to, they weren't permitted in the hospital just because we wanted to minimize the risk to everybody, but they were able to listen into all the rounds. And then what they would do is call the families. Not that the physicians wouldn't, but we can't have, we have to get through all the rounds before we can start our phone calls to families. So our students would be connecting with families and providing them with the day-to-day, the new data, the updates for the day, and then we would follow up later in the day for whatever they wanted to discuss with us, but they would already have the basics of the information, would already know what the plan of the day was. And so we basically created new relationships between physicians in training and family members, and that support was really necessary. The other thing that we did, and this isn't a we, again, all credit to my colleagues. There is if you Google this, you'll find a wonderful article. It's written in nj.com. And it's by my colleague, Dr. Emily Damuth, who's an intensivist here at Cooper. And the title of the article is we hold the phone and we cry. We hold the phone and we cry. And in that article, I couldn't possibly do it justice, because she just tells some real poignant stories in there, much better than I ever could. And ways that you can connect with people when you can't connect with people, right? And I've just been so amazed at how people find a way to connect. And I highly recommend you read that article by Dr. Damon.
It's such a testament to the resilience too, isn't it?
Totally. Yeah, totally.
Yeah. Everybody is, forever people ask me, can you teach compassion? How do you answer that question, Steve?
So
I have my own feelings about the question. But.
Sure. So I'll tell you what I think, and this is one of those scenarios where not only do others know more about that than I do, but obviously the moderator knows probably a lot more about that than I do. So I'll tell you my opinion. You can tell me what you think. So I think the answer to the question is yes. And there is some data behind that. My colleagues, Sundip Patel and others, we published a systematic review in PLOS ONE last year, 2019. And what we found was that there have been more than 50 studies in the medical literature. And in this particular study, we focused on physicians in training in order just to get our arms around it, because otherwise it would have been too many studies. And what we found is that of those 54, 75% of them, the investigators found that compassion training moved the needle in some way on some compassion behaviors in 3/4. So I think that's evidence that you can in fact learn, but really what you're learning isn't behaviors. It's not necessarily how to care more in your mind or in your heart, but how you behave to another person can certainly be taught. The key is that you have to want to. And what I mean by that is that there's data from Carol Dweck and colleagues at Stanford University, and much of her work is in the domain of education and teaching young people. So she wrote the book Mindset. Yeah. And in education, there's a lot of talk about mindset. And what they found in their group was that in this case, it was empathy training that they were doing. Empathy could be learned, is what they found, but you have to have the right mindset. And what they meant by that is you have to believe that empathy is a skill, not a trait. And Dr. Jamil Zaki wrote a wonderful book called War for Kindness, which I highly recommend, where he talked a lot about this. And rather than having a fixist thinking where empathy is a trait, meaning you either have it or you don't, you're either wired that way or you're not, if you view it as a skill, then you can have a growth mindset and believe that you can in fact get better at it. So what Dr. Dweck and colleagues and Dr. Zaki and colleagues found at Stanford is that if you believed you could get better at it, you would. If you didn't believe you could, you would not. So you have to believe, and the evidence supports that caring behaviors are something that you can actually get better at because it's a skill. If you just think you're either wired one way or you're not, you will never put in the right amount of effort to get better at it. So that's what I think about.
That's helpful.
What do you think?
I think we're born with the capacity for empathy and compassion, and I think it's been an evolutionary benefit for us. Mm-hmm. But I agree that, not everybody has the same level of predisposition or ability to sense the thoughts and feelings of other people. But like you said, and like Jamil Zaki says, I think it's something that, is a spectrum, and that it can be increased, improved, and trained. The other thing, though, that I think is that, I was reading, I was very influenced by this guy, C.D. Batson, who developed this empathy, altruism hypothesis. And he's a very well-respected researcher who talks a lot about how empathy actually leads to compassion and to altruism. But he had to adapt his hypothesis because he said, there's a key ingredient that I left out in my initial model. And that is that you have to value the welfare and well-being of that other person in order to experience compassion. You have to care. If you don't care about that other person, and as you were saying, Steve, about that other person's full humanity, you're not going to experience compassion. And so that leads me into this whole idea, well, A, the hidden curriculum kind of undoes some of our caring. B, implicit bias, if not racism, undoes some of our caring. How do we address all of those things as we think about how to improve and how to help others learn to exercise that muscle and develop additional skills to express their compassion, which I do think is innate. So I think it's complicated. I do totally believe it can be taught and learned and exercised and improved. And like you said, I think we're all a work in progress,
One of the things that, because sometimes I'll get asked a question, okay, well, how do I do it? Right? Like, so what are the 5 things, right? And, as if it's a checklist, right?
Yeah.
I don't buy that. I just don't. So what I mean is that I think really if you're going to get better at compassion, there's really 3 things that are necessary. This is, again, this is just in the domain of my opinion, right? Number 1, you have to realize that there's an evidence base behind compassion. And so what we were talking about earlier and going through all the studies, I think there's evidence that there is science in the art of medicine and the science is strong. And once you realize that it's not, what I mean by that is you don't just think of compassion as a nice to have, right? Like my colleague Anthony Mazzarelli will say, it's not just dessert after the entree, right? It's not just, well, if you have time for compassion after you do all the technical aspects, yeah, that's okay. It's not, it actually matters in measurable ways, not just meaningful ways that we've always thought of. So that's 1. Number 2 is you have to believe you can get better. So like we're talking about growth mindset, if you think of it as a skill, not a trait, as Jamil Zaki would say. And then the last thing is this concept of time, because oftentimes I'll hear people say, well, and actually there was a study years ago that found that 56% of physicians in training who were surveyed thought that they didn't have time for compassion. Think about that, right? That's scary. But when we went through all the evidence and we found 6 studies that actually measured it, they literally timed it. And what they found is when you synthesize all the evidence, that a meaningful expression of compassion when measured precisely is typically less than a minute. And some people actually bristle at what I just said because they would argue actually it doesn't take any time at all, because you can go through your day with this brusque efficiency, letting people know just how busy you are, or you can go through your day and treat everybody with compassion. If you had a stopwatch, it actually didn't take you any more time. Mm-hmm. So, we must have. So, I said, realize the evidence base, have a growth mindset, but then also realize that it actually doesn't take more time. Mm-hmm. In fact, just real quick, I'll also share with you, there was a study from the Wharton School at University of Pennsylvania that studied a concept called time affluency. And what they meant, the investigators meant by time affluency was they meant the feeling that you have plenty of time, that you're not in a hurry. And then they randomized subjects to 4 different uses of time and measured how they felt about the time that they had after their different uses of time. And they randomized them to spending time on themselves, wasting time, getting a windfall of free time unexpectedly, and spending time on other people. And what they found was that the only use of time that increased time affluency, meaning the feeling like you have plenty of time, was spending time on other people. So it seems like spending time on other people changes how you feel about the time that you have. And so we have to not let ourselves fall into this. The third part is time, and not letting us think that we don't have time for compassion. In fact, the evidence would support that giving time gives you time.
Yeah, it's interesting. I was brought into medicine by my father-in-law. I used to make rounds with him. And he would sit down, next to the patient at the bedside and just always looked like he had all the time in the world. Mm-hmm. But in fact, he spent whatever time he had. He always taught me that sitting down and just making a connection and being present and making eye contact is experienced as almost like time stopping in place. You're just so present with that other person that is perceived as lengthening the time available and the time spent. Yeah. It's just so valuable. More questions for you. There's some questions in terms of demonstrating compassion for patients and people of color. Sometimes it's difficult to, I guess, cross into other kinds of ways of behaving when you may, this person is saying, when sometimes we're seen as being the enemy. I'm not completely sure about the interpretation of the question, but it's about demonstrating compassion for others who you may perceive as being unlike yourself or who may perceive you as being unlike themselves.
Yeah, it's a great question. And I think what I'll just say broadly is that I don't know, but I want to learn as much about that as I can. And we're working very hard to try to study patient experience of clinician compassion and to understand how it may be similar or different between peoples of different backgrounds, whether it's race, ethnicity, or socioeconomic status. And I think we don't have my review of the literature so far is we don't have a super detailed understanding of those similarities and differences. I think that they're very important. I think that it's not just, we know that clinicians often have blind spots. They have blind spots about their compassion. They may perceive themselves as the most compassionate clinician, then when you ask patients, they say something very different. Mm-hmm. And that's been shown over and over again in the literature. It may also be true with behaviors that communicate a lack of compassion or a lack of caring. There may be subtle behaviors that clinicians aren't even aware that they're doing that communicate something to patients that are either different by race, ethnicity, or socioeconomic background that they don't even know they're doing because it's implicit bias. And so I don't have a super detailed response to that. I can just tell you it's something that I think about a lot and I think is ripe for additional research.
Yeah. We do know that patients are given less pain medication. They're treated completely differently even when they have the same presenting symptoms. If they're from different backgrounds, that has been shown that part of the reason why outcomes differ. I think we are at the end of our time, which is sad. This has been really fun. Thank you so much, Steve.
Thank you.
Yeah, no, it's been just so great to have you here. So we appreciate your taking the time and spending your time with us, especially when you're on service. Thank you very, very much. And I want to thank all of those folks who are listening in. I hope you'll keep an eye out for the recap of this week's sessions. And if you want continuing ed credit, to look for that link. There will be a continuing ed post test later on coming out. Also, we look forward to having you back on Tuesday for Reflective Writing, a tool for self-compassion. This is going to be a workshop with Liz Mitchell, an ER doc here in Boston Medical Center, and Dr. Sarah Wingirter, also from BU School of Medicine. So enjoy the rest of your day and the weekend ahead, and thank you for joining us. Take care, all.
Bye-bye. Thank you.
Thanks, Dave.